So going to the talk, so AKI in cancer is a very important and a very evolving field. And the epidemiology, so I will be covering the basics of the epidemiology of AKI in patients with malignancy, the etiology of AKI in a cancer setting, AKI in some special situations which we need to understand and how we can manage these situations. What is the diagnosis of AKI, prevention and management of AKI in cancer, and our own data to see what is our incidence of AKI. So coming to some basics, the incidence of AKI can be quite high in the cancer setting. I think most of the times the early AKIs are missed, and in some series up to 30% AKI has been reported. It is higher in patients who are hospitalized and in the ICU, and malignancies associated with the highest risk of AKI include myeloma, bladder cancers, and leukemia. Critically ill patients with cancer and bone marrow transplants carry a high risk of AKI, and the burden of AKI is huge. And if AKI occurs, the prognosis in all aspects of cancer management gets affected. So what is the epidemiological data published which is available? In a Danish cohort, around 1.2 million people with cancer were studied, and 1 year and 5 year risk of AKI by rifle criteria was determined, and it goes up to around 25%. And dialysis requirement was seen in 5%, and they did quite badly. And the malignancies at risk in their cohort was renal cell carcinoma, myeloma, HCC, and metastatic cancers. Kitchlow et al. Did a populational cohort, again by the rifle criteria, where the immediate 1 month risk of AKI was 9.3%. Again, myeloma, bladder, and leukemia largely featured in the cancers in which AKI was most common. And Perron et al., which is a more recent data, had 2,800 patients with metastatic cancer, and the AKI went as high as 40% in these patients. In this data, which was studied from 1967 to 2023, AKI due to chemotherapy and other agents reported has largely increased. If you look at it, even Southeast Asia and Asia, from a bare reporting of around 2,000 to 3,000 patients with chemotherapy-induced AKI, it has gone to a whopping more than 11,000 patients with chemotherapy-induced AKI. Now, with large use of immunotherapy, targeted therapy, CAR T cells, the incidence of AKI has increased. So the etiology of AKI in cancer patients can be very much multifactorial. So you need to look at the patient, what the patient is receiving, and what are the treatment-related side effects. So the treatment-related side effects can include because of chemotherapy, because of BMT, because of targeted therapy, nephrotoxic agents concomitant with that. In our parts of the world, a lot of native medications are taken for cancer, crystalline nephropathy, immunotherapy, and radiation. Tumor lysis syndrome and TMA can occur due to the cancer itself, as well as the treatment related to the cancer. Glomerular diseases can occur due to various mechanisms. Obstruction, very common. We see a lot of CA cervix and genitourinary cancers presenting with obstruction. Has to be identified. AKI generally recovers. Infiltration due to the cancer itself may not be a big part of it, but does occur. Hypercalcemia and hemodynamic disturbances. These are the multifactorial etiologies of AKI in cancer patients. Now coming to the cancer and treatment-specific factors, sepsis is probably one of the most important causes of AKI, especially in the cancer setting in the ICU and hospitalized patients. Post-nephrectomy, especially in RCC, both partial and radical nephrectomy, hematological malignancies, obstructive nephropathy, stem cell transplants, hypercalcemia, sometimes missed, nephrotoxic chemotherapy, paraneoplastic glomerular diseases, and tumor lysis syndrome, especially in the high tumor burden and hematological malignancies. Patient-related elderly, especially patients above the age of 65 years, so many of them have hypovolemia because of various factors. A pre-existing CKD. This is very important to determine because these come under the highest risk of AKI. Diabetes, hypertension, heart failure, liver disease, which are all risk factors for AKI. concomitant use of RAS inhibitors, NSAIDs, and diuretics. And I want to mention here PPIs because that is one of the common risk factor, especially for ICI, that is immunotherapy-induced AKI. Antibiotics, hyponatremia, critically ill patients, and the use of native medications. These are the risk factors of AKI in cancer patients. So if you look at it, the chronic kidney disease, the hazard ratio is around 1.8, quite high, and it has to be documented so that we know that they are at a higher risk of AKI when we start treating these patients. So I'm not going to go much into detail with monoclonal gammopathy because my next speaker is going to speak on it, but it's a very important cause of AKI in cancer. Multiple myeloma accounts for more than 50% of the cases with AKI. Cast nephropathy, which is a myeloma-defining event, can cause severe AKI requiring dialysis. And we have very good clone-directed therapies and which have better kidney outcomes. Monoclonal gammopathy of renal significance is a very important entity not to be missed. A kidney biopsy is very useful in order to determine this, and clone-directed therapy can actually improve outcomes. And extracorporeal therapy for light chain removal is fairly controversial, needs more data. Coming to hypercalcemia. Hypercalcemia is one of the most common causes of AKI in patients admitted to the ICU. The mechanisms can be several: secretion of PTH-related protein, local osteolysis, ectopic secretion, tumor production of vitamin D. Kidney manifestations, it causes arterial vasoconstriction leading to AKI, distal RTA causing chronic tubular dysfunction, calculi again which can cause obstructive nephropathy and nephrogenic DI. Management generally involves volume expansion, loop diuretics if there is fluid overload, calcitonin. But please remember, all these are very transient treatments, and we may have to resort to bisphosphonates and denosumab, especially if patients have low kidney function. Hemodialysis may be required. The calcium is more than 18 mg per deciliter. Coming to obstruction. Obstruction is very common, and most of the times we think obstruction is just an extrinsic obstruction. But in cancer, it is both an intrinsic as well as an extrinsic compression. And especially in our parts and where we do our clinics, GU as well as gynecological cancers come in advanced stages, and most of them present with severe bilateral obstruction, which may require immediate treatment with either stenting or percutaneous nephrostomy as early as possible. Some of these are delayed, and we do end up dialyzing these patients with obstructive AKI. You can also have intrinsic obstruction with crystals, especially in tumoritis syndrome and methotrexate toxicity. You can also have nodes which are encircling the ureter. BK virus infection in the setting of hematological stem cell transplant can be very florid, and AKI is quite common. And of course, in prostate as well as bladder cancers, you can have extrinsic compression. So when a patient comes with AKI, an urgent ultrasound or a CT is very, very important in determining whether there is obstruction or not. Coming to chemotherapy, a large part of AKIs are due to chemotherapy. Now, conventional chemotherapy, we can't do away with. Platinum-based compounds, especially cisplatin, is widely used in most cancers. Antimetabolites like methotrexate, pemetrexed. Pemetrexed causes a lot of AKI because it is used in conjunction with other agents, and we have seen a lot of AINs with it. Anti-tumor antibiotics like mitomycin C used in bladder cancer, and alkylating agents. All these can cause different types of AKI in cancer patients. Cisplatin, which is a linchpin in chemotherapy regimens, is quite nephrotoxic. It can cause up to 30% of AKI, generally non-oliguric. Severe magnesium wasting can be seen, and which will precipitate more AKI. Generally, it's hydration, and other things like IV magnesium, mannitol, amiloride are yet to be studied. Some patients with chronic hypomagnesemia due to cisplatin, we do use SGLT2 inhibitors, which helps increasing their magnesium levels. So there is a reason this year, Gupta et al. Had a scoring, a simple scoring based on 9 parameters like age, hypertension, diabetes, the dosing of the drug, the creatinine, albumin, magnesium. So all these are generally done as a part of workup, hemoglobin, WBC count, and platelet count. And basically they found, and it was almost a 24,000 patient cohort, it's easily available online, and you can actually check the patient's risk of having cisplatin-induced nephrotoxicity. Now, most of the times we don't have much of a choice. What do we do if we can't use cisplatin? So there is something called as carboplatin, which is again a second generation one, slightly better tolerated, but has less efficacy than cisplatin. Primary renal excretion is around 90%, but there's no tubular secretion when compared to cisplatin. And generally used if patients can't tolerate cisplatin. So there is a formula called as Calvert's formula, which can be used to calculate dosing of carboplatin. So generally we try to keep the area under the curve values of 5 to 7 mg per ml. Now coming to methotrexate high doses especially are used in hematological cancers. Anything more than 500 mg per meter squared is considered toxic. Leucovorin, which is an active metabolite, can be used in order to offset the toxicity due to methotrexate. Glucarpidase is actually a very effective drug which brings down methotrexate levels within 15 minutes. However, because of cost, it is not very easily available in our setting. And dialysis generally has a limited utility to bring down methotrexate levels. Generally, even if it brings it down a little bit, it generally rebounds after a couple of hours. Gemcitabine causes TMA mainly, and treatment is largely supportive. Eculizumab, again, can be used in certain settings, and there are some case reports. I specifically wrote Pemetrexed because this is like methotrexate, but we are seeing it being used a lot, and a lot of AKIs due to Pemetrexed. There's higher AKI when used in a combination therapy. They generally use it with carboplatin or cisplatin. AIN is generally the biopsy finding, and generally avoid concomitant nephrotoxic agents. Hydration, folate, and B12 can be used. Ifosfamide is more nephrotoxic than cyclophosphamide, causes ATN and mitochondrial toxicity. There are no specific medications to prevent AKI due to ifosfamide. Hemorrhagic cystitis, I think we can manage it with Mesna and hydration. Immunotherapy has revolutionized cancer therapy. We have more than 10 immunotherapeutic agents which are available for more than 20 cancers. Basically, they disrupt the immune regulatory checkpoints and activate the T cells against tumor cells. So basically, the side effects which we get are mostly immune-related side effects. Actual ICI-induced AKI is around 3 to 5%. Generally, it is seen around 14 to 16 weeks. Stage 3 AKI in more than 50% of the patients. Generally, if there is a history of the other immune-related side effects like thyroiditis, skin rash, or GI side effects, suspect AKI also. AIN is the most common pathology. There are some data to suggest that a PET CT may be useful to see whether there is the AIN is due to ICI. Now, there are a lot of position statements, and last month the ASON came up with a position statement which says that if anybody is on ICI and you've ruled out other causes of AKI, then you should biopsy these patients in order to see the reason, because it is the gold standard to see whether there is ICI-induced AKI. So basically what happens, if somebody is, the other thing is, some of these patients on ICI are metastatic CAs. So you need to sort of weigh the benefit versus risk of giving the therapy. So if somebody is on ICI, you feel that there is AKI, you've diagnosed AKI and you feel it is because of that, stop it for 3 or 4 days. Stop the concomitant medications like NSAIDs, PPIs, etc. and then see what is happening with the creatinine. If it is not improving, then we should biopsy to see what is going on. If it is improving, then you can restart it and again closely monitor this patient. You biopsy and it is an AIN on the biopsy. You can start 0.8 mg to 1 mg per kg per day of steroids and then restart once the AKI has settled. So this is what we are currently practicing in cases of ICI AKI. In CKDs, actually ICI are not removed on dialysis. Generally, it is degraded by proteolytic degradation. So anybody with even end-stage kidney disease, you can use ICIs. But a careful monitoring is required because AKI can worsen the CKD faster. Transplants, high risk of rejection. So generally, there are some case reports of using mTOR inhibitors with dynamic steroid use in order to prevent AKI in these situations. Cellular therapies nowadays being used for resistant B-cell lymphomas causes a very bad cytokine release syndrome and AKI. Risk factors are generally previous BMTs or higher grades of cytokine release syndrome. Tocilizumab and dexamethasone have been tried in these situations. Generally, the mortality is very high. Targeted therapy are used very, very commonly in most cancers nowadays, especially renal cell carcinomas. VEGF inhibitors and tyrosine kinase inhibitors are used. They cause multiple mechanisms including hypertension, TMA, AKI, proteinuria, as well as pre-renal AKI in many patients. The good thing is, generally a dose reduction or stoppage of the drug can lead to reversal of symptoms. So it is important to identify AKI due to these drugs. Bone marrow transplant, again, multiple mechanisms for AKI, but if AKI occurs, it's almost 50 to 100% mortality. Whatever AKIs we have seen in our setting, we've seen most of them die when they have developed AKI. We have to treat the underlying etiology. A lot of risk factors for developing AKI in a setting of BMT. So it can be because of the direct conditioning effect, drug effect, CNI toxicity, BK virus, sepsis, very, very common, diarrhea, graft versus host disease, and later on, you can get transplant-induced TMA as well as direct tubular toxicity and glomerular diseases in the setting of HSCT. TMA due to cancer as well as therapies due to cancer are not very uncommon. And what we have to understand is recognize it. TMAs associated with conventional chemotherapy is generally not good. It's dose dependent and generally progressive. VEGF inhibitor therapy, generally we can stop the therapy and there is a chance of reversal of the TMA. Treatment is largely supportive. Plasma exchange and eculizumab may not be very useful in these settings of TMA. So again, this is the classification of TMA in cancer patients where you have cancer-related TMA, cancer drugs-induced TMA, one caused by chemotherapy regimens and mainly caused by anti-VEGF agents, and you have the bone marrow transplant-related TMA. Tumor lysis syndrome is an oncological emergency. It can either occur spontaneously or after treatment begins. Hematological malignancies and malignancies with a very high tumor burden are at higher risk. Venetoclax is being used very commonly nowadays for CML and blast crisis, and it is an independent risk factor for developing tumor lysis syndrome. So it is very good to give rasburicase, and in our center we practice this where we give rasburicase preemptively before we start chemotherapy in these patients. So largely we diagnose it using the Caro-Bishop criteria. Treatment is generally aggressive hydration, rasburicase, especially in patients with high risk. Allopurinol, you have to dose modify it in renal failure. Febuxostat, sometimes do not alkalinize the urine because it's going to precipitate the calcium phosphorus and cause stones, and hemodialysis as per necessity. So pseudo-AKI, so everything is never black and white in nephrology. So creatinine being a very poor biomarker, secretion occurs through 10 to 40% through the OCT and MATE channels. So a lot of targeted therapies which inhibit these channels and therefore cause a rise in creatinine, and it's generally a pseudo-rise in creatinine. And it's important to recognize this so that we do not stop therapy. So a lot of drugs are actually implicated. Many of the TKIs and some drugs used in prostate cancer, etc. are implicated. So whenever you are suspecting pseudo-AKI, repeat the creatinine and see. If you still feel that this may not be an actual AKI, then you can use cystatin C and see whether the GFR is the same as the baseline GFR. If that is also not contributory, then you may have to do a measured creatinine to see whether there's an actual AKI or not. Measured AKI in our settings may not be very easy, but I think in some drugs like crizotinib, etc., are very notorious to cause pseudo-AKI. So recognizing this is very important. So diagnosis, I think I have explained. Identify the patient at risk, image immediately, get all the biochemical parameters, make sure you get an entire electrolyte panel, keep in mind TMA, and a urine analysis is a must. So if it's pre-renal, I think Dr. Manisha ma'am had already elucidated in her talk. If it's renal, see if there's an indication for a kidney biopsy, and if it's post-renal, treat accordingly. These are the indications for biopsy in patients with AKI and cancer. There's a delayed recovery, AKD in myeloma, in NGUS, and other electrolyte disorders where you don't know what's happening. So general principles is pretty much the same. Have a knowledge of the risk factors, have preventive strategies, work up and detect AKI early, and treatment of AKI and follow-up. So AKI in cancer can cause inadequate cancer therapy. It has a very high mortality, especially in hospitalized patients, and you can give inadequate dosing of drugs. So it's very important to identify, see the GFR, and give your drugs accordingly. I think it's been illustrated in the previous talks. AKI, even in cancer, is going to progress. It's very important to follow up these patients in order to see what is their outcomes as well as prognosis in terms of renal function. So this is our preliminary data. We started focused onconephrology clinics in June 2022, and total number of new consults we saw was around 2,300, where we saw AKI in almost 51% of the patients. This is a quaternary center, so probably the patients we were receiving were already quite sick when they came, and AKI on CKD was seen around 13% of the patients. The major risk factors we saw was higher age, as well as a large number of people were on PPIs, and the type of cancer, hematological formed a large part of it, urological, as well as myeloma. Obstruction was the very common cause which we saw as a cause of AKI, and a large number of patients had post-renal cause. And we did biopsies in 25 patients, and AIN was the most common pathology that we found. So stage 1 AKI was more common. Stage 3 AKI and dialysis requirement was a little less common. A large number did recover, but unfortunately almost 55% of the patients are lost to follow-up. And this is what we probably have to bridge the gap in our setting. So AKI is very common among cancer patients. Obstructive cause should be ruled out. Kidney biopsy should be performed whenever possible. Identify risk factors and stop the modifiable ones. And AKI in cancer carries a much poorer prognosis. Thank you, and thank you for the patient.
Sri Lanka Society of Nephrology for inviting me to talk on something which has interested me for almost 27 years. So if I had to talk on thrombotic microangiopathy, it would take almost the whole day. But primarily, we suspect it when there is an AKI with disproportionate anemia, thrombocytopenia, and perhaps hypertension. If there are low complement C3 levels, that would indicate that probably this is an HUS caused by alternative pathway overactivity. Proteinuria, hematuria, and casts in the urine are suggestive. And as we know today, thrombotic microangiopathy requires a genetic predisposition and a trigger, which could be pregnancy or the postpartum. In our setting, snake envenomation. Dr. Rajiva referred to solid organ and stem cell transplant and chemotherapy and cancer. Finally, almost any unexplained AKI could be a thrombotic microangiopathy. The diagnosis of thrombotic microangiopathy rests on demonstrating a microangiopathic hemolytic anemia. That is, it is a non-immune hemolytic anemia with the presence, perhaps the best test of all, is the demonstration of more than 1% of schistocytes, either seen by ourselves or by an experienced pathologist, thrombocytopenia. Now, there will be situations in which this complete peripheral picture of hematological involvement is not seen, a condition called renal-limited thrombotic microangiopathy, where a renal biopsy is what is required to make the diagnosis. This is our own center data for about 15 years. Not working. So the large majority of the patients that we have seen have been pregnancy and postpartum, followed by snakebite-induced thrombotic microangiopathy. If it appears that, thank you. if it appears that the number of complement mutation AKIs are thrombotic microangiopathy are small, it's because for many years we did not have access to genetic testing, something that we've only started doing in the last 5 or 6 years. So this is the current classification and the approach suggested. Having made a diagnosis of a thrombotic microangiopathy and AKI, we need to immediately look for tests like the ADMTS13 activity and anti-factor H antibodies, that is, looking at either TTP or acquired complement-mediated HUS. These have to be done within a period of days. Over a period of time, we then try to identify a trigger and decide whether we need additional tests to further decide about the cause of thrombotic microangiopathy. And having made a diagnosis, started treatment, our treatment may need to be modified as tests like genetic tests, which take weeks to come in, may become available. I'm going to touch first on the most common in our setup, that's pregnancy-associated thrombotic microangiopathy. And there are 4 main causes: TTP or thrombotic thrombocytopenic purpura, the HELP syndrome, complement-mediated HUS, and the catastrophic antiphospholipid syndrome. It's important to realize that a thrombotic microangiopathy in TMA or TMA in pregnancy increases the mortality risk by 5 times and produces end-stage renal disease in up to half of these patients if inappropriately treated. TTP is commonest. All the thrombotic microangiopathies actually are common late in pregnancy on the postpartum period, but TTP is one which can even arise in the first trimester of pregnancy. It's characterized by severe thrombocytopenia and neurological symptoms and milder renal damage, although there are patients who have been reported who have become dialysis dependent and gone on to end-stage renal disease with TTP. The diagnosis rests on demonstrating a low, less than 10% ADMTS13 activity with or without the presence of inhibitors in the patient's plasma. The management of an inhibitor-induced thrombotic TTP is by plasma exchange, started as early as possible with 1 to 1.5 ml plasma volumes per daily, and it has to be accompanied by steroids and or other immunosuppression. Although cyclophosphamide is not recommended during pregnancy, azathioprine and calcineurin inhibitors are safe, and recently caplacizumab, a specific antibody, monoclonal antibody against the von Willebrand factor, has become available and has been reported to be safe in pregnancy. If we have the Upshaw-Schulman syndrome or congenital TTP, then the treatment is initial plasma exchange followed by plasma infusions every 2 weeks with small amounts of plasma. And recently, recombinant ADMTS13 has become available and has been reported to be successfully used in pregnancy and postpartum patients. The commonest form of all is preeclampsia and the HELP syndrome. It occurs in 0.5 to 1% of all pregnancies, and more than 2/3 of these are late or during the 3rd trimester or in the postpartum period. It's important that there is an overlap, especially in the postpartum period, with a much more sinister disease like the complement-mediated hemolytic uremic syndrome, and therefore the two have to be distinguished. This is a test which has been shown to have an excellent sensitivity and specificity at 72 hours postpartum if the LDH is more than 600 and or the creatinine is more than 1.9. That's suggestive of a complement-mediated HUS and not HELP syndrome. The SFLT1 placental growth factor ratio has been validated in the PRECISE study and shown to have an excellent negative predictive value of 96%, but a positive predictive value of only 65%. And so alone, it should not replace clinical criteria for making this diagnosis. It's very important to realize that the only treatment required for a HELP syndrome is delivery. Far more sinister is the complement-mediated HUS, which usually follows a normal pregnancy and takes place in the postpartum period. It requires a genetic predisposition. Recently, Narayan's paper from SGPGI showed that 4 out of 7 of their postpartum HUS patients had acquired autoantibodies about factor H, and I'll speak more about that because that's our very own disease in India. The postpartum period is considered one of the major triggers for the complement alternative cascade to be initiated. And the treatment of this has been typically in all literature says that the treatment should be with eculizumab. Ravulizumab has also been shown to be safe, but unfortunately, these are not available to us in India. And I suspect that the same situation is in Sri Lanka. And so, although plasma exchange is not today recommended by Western literature, that's what we would end up using. We found in our paper, this was published in the Asia Pacific Journal of Nephrology about 2 years ago, a high prevalence of CFHR deletions along with the H3 haplotype in postpartum HUS patients. And we have treated all our patients with plasma exchange. Now, if you look at these studies, these are European studies which used a mix of plasma exchange and eculizumab. The French study, which is old, about 14 years ago, showed dismal results with plasma exchange, with 62% of patients becoming end-stage renal disease by 3 months postpartum. But we had a much better response to plasma exchange. 70% of our patients responded, and only 30% were dialysis dependent at 30 days, and by 6 months, about another 10% of these had improved. The catastrophic antiphospholipid syndrome. Antiphospholipid syndrome per se is known to be associated with thrombotic, arterial and venous thrombotic events, and also in some situations, pregnancy losses, especially early. But the catastrophic, and these are large vessel thrombosis, but the catastrophic antiphospholipid syndrome is a thrombotic microangiopathy which affects the microcirculation and which can present as a TMA again late in pregnancy or in the postpartum period. There is an overlap as antiphospholipid antibodies activate the coagulation cascade and also the complement pathway. So there's a big overlap in these. Skin necrosis is supposed to be one of the striking clinical features. However, I find that ischemic gastrointestinal tract is one of the worst prognostic features. We've lost all patients who had extensive gastrointestinal involvement, and all the patients whom I have seen have been secondary APLAS, catastrophic antiphospholipid, coming in lupus patients. Patients who have triple antibody, lupus anticoagulant, anti-beta 2 GPI, and anti-cardiolipin antibody, all three positive, have a high risk profile for the CAPS. Positive titers with TMA is a very poor prognostic sign. It's a disease that's prevalent more in women, 70% of patients, and this is what it looks like. You can see a complete occlusion here of a glomerulus, that's a bloodless glomerulus. This is an arteriolar thrombosis. This is an ischemic glomerulus with an arteriolar thrombosis, and here you can see entrapped RBCs in the microthrombi. The mainstay of treatment is high volume plasma exchange early, along with anticoagulation, IVIG. Second line agents include other immunosuppressive agents, some of which do not, their role has yet to be defined. A therapeutic algorithm to summarize: TTP, plasma exchange, now caplacizumab and recombinant ADMTS13 help. Delivery: complement mediated. If complement inhibitors are not available, plasma exchange, and CAPS, it's plasma exchange. I'll jump to TMA in snake bite, again a disease probably common in the Indian subcontinent. Right from 1986, when Date and Shastri at CMC Vellore described 16 cases, Dr. Gopal Krishnan, who's here, described cases with cortical necrosis, so it's a very severe disease. Today, the terminology recommended is that we call these TMAs to be arising in a situation of venom-induced consumptive coagulopathy, which is an activation of the coagulation cascade by procoagulant toxins. There are many snake venoms. In Asia, all vipers. In the Middle East, vipers. And in Africa, viper bites are known to produce venom-induced consumptive coagulopathy. In Australia, there are a number of snakes for which it has been reported. And in South America, botrops and microcrurus specimens. If the proportion of schistocytes begins to increase in a peripheral smear, that has an excellent predictability for a TMA with AKI in the setting of snake envenomation. The cobra venom factor, and this was alluded to yesterday in the talk on C3GN, activates, it behaves like a C3 convertase which activates the alternative pathway. And Russell's venom, viper venom, also contains DRKILN1, a heparin-dependent inhibitor of activated protein C, which also causes microthrombi. The Botrops and Microcurus snakes from Brazil have been shown by Gabriel Tanaka to produce complement fragments in increased amounts, C3A, in the serum, and also to produce in vitro hemolysis of sheep blood with various Microcurus venom specimens. So most cases of snakebite-induced TMA are reported from India, Sri Lanka, and Australia, but it may be significantly underreported from many other parts of the world. So it resembles HUS with a predilection for renal end organ damage, and it's seen in 20% of bites in India, about 10% in Australia, and various other parts of the country. When there is TMA, there is a much more severe oligoanuria and dialysis dependence as compared to patients with venom-induced consumptive coagulopathy without TMA. The time to resolution is also longer. There is more VICC at presentation in patients who do not have TMA, and a much higher need for renal replacement therapy in these patients. So this is a systematic review which looked at how we should report and what we should do. Dialysis-free survivals reported in India and Sri Lankan studies and Australia as well are pretty good. The preferred term should not be either TTP or HUS because snakebite, the condition is distinct, but snakebite associated TMA. Although antivenom remains the standard of care, this systematic review did not find that there is evidence that antivenom prevents TMA, and it concluded that therapeutic plasma exchange cannot be recommended as routine clinical practice. However, there is a study from Sri Lanka which was published a few months after the systematic review, which told us that they looked at 47 patients, 21 of them received therapeutic plasma exchange and 26 did not. The overall incidence was about 8% of TMAs, and the best renal recovery the chances of renal recovery were 5 times higher in those patients who received plasma exchange. The time to correction of microangiopathic hemolytic anemia and platelet count was faster in the patients who received therapeutic plasma exchange as compared to those who did not. So our own experience is similar. We've had 23 patients, children and adults. 13 of them received plasma infusions and 10 received plasma exchanges, a median of 2.5 sessions, and complete recovery was seen more in patients who received plasma exchange as compared to those who did not. This probably gives away what I'm talking about, but this is a patient who presented like from a rapidly progressive glomerulonephritis and had already received methylprednisolone. We biopsied to know what type of crescentic nephritis it was, and instead this is what we found. Thrombotic microangiopathy of the arteriole with an ischemic glomerulus, entrapped RBCs, and this is what is mesangiolisis with glomerular apoplexy. And this patient turned out to have, when we did an MLPA, the CFH exon 23 of the CFH gene, there were 3 copies, and there was 1 copy of exon 6 of the CFHR1 gene. So what we had was a hybrid gene caused by non-allelic homologous recombination, which led to a protein which had binding sites of complement factor H, but no enzymatic activity. In fact, it inhibited the normal complement factor H. So what is the role of a renal biopsy? We've done many biopsies, and those patients who present like the one I described, who do not have the classic peripheral hemolysis and thrombocytopenia, it's only a biopsy which will show you these occluded glomeruli, bloodless glomeruli with occluded capillaries. This is a more chronic mucoid intimal hyperplasia. This is entrapped RBCs, and the most severe form, which has been described in thrombotic microangiopathy, both in snakebite and pregnancy and in other conditions, is cortical necrosis, which does not recover. So when should we go for genetic testing? This is a 2024 guideline from the consensus conference. They say in all cases of thrombotic microangiopathy, autoantibody analysis for anti-factor H and ADAMTS13 activity is mandatory. In addition, patients should receive a whole exome sequencing and also a MLPA for copy number variation. Sometimes, as in this, we had less than 1 year old patients, and we found both anti-complement factor antibodies and also novel pathogenic mutations in the DAGKA gene. How should one manage a patient with thrombotic microangiopathy, specifically HUS? TTP is straightforward today. Well, this is a 2016 recommendation, but as I said, although they recommend eculizumab as a first-line treatment, it's not available to us. It may become available next year in India. Till then, plasma therapy is indicated in anti-factor H antibody HUS, and in India, 56% of children with HUS have anti-factor H antibody-mediated disease, much higher than in the Western studies where it is 5 to 20%. And recently, the paper from SGPGI showed that there is a similar incidence in some adult group patients with HUS. About 57% had anti-factor H antibodies. There's no doubt that eculizumab is superior to other therapies. The improvement is in 5-year survival is 78% compared to 39% without. But as I said, it's not available. So what's the difference in Indian patients? Unlike European cohorts, anti-factor H antibody HUS is seen in 50% of both pediatric and perhaps adult patients. We need larger adult studies. The pediatric study from AIMS was the largest in the world, 436 patients. No other study is even 50 patients. So that's a huge data. And international guidelines, therefore, may not be applicable to countries like ours, where the pathogenesis is different and eculizumab is not available. So plasma exchange has been suggested by the Pediatric Nephrology Society of India as the first-line therapy, and it's associated with excellent results. The 5-year survival, renal survival, is above 80% in anti-factor H antibody disease when plasma exchange and immunosuppression were combined. This is the paper from SGPGI, which shows that the similar results are obtained in adult patients with anti-factor H antibody disease. Both patient and renal survival is above 80% in patients. And so we can also today, there are papers. This is Dr. Karalingatisu's paper from PGI Chandigarh, which shows that we do not need very intense regimens. The median number of plex cycles in children was 11. In Narayan's paper, it was 7. So we can come down on the number of plasma exchange cycles required. And that's what led to this commentary, which I wrote 2 weeks ago in Indian Journal of Nephrology, that anti-factor H antibody HUS is our disease, India and perhaps in the Indian subcontinent, and we need to find treatment options for it. So what is available? Plex. These are all the new agents. As I said, they are not yet available in India, except that iptacopan is now under trial in India, and we have randomized 3 patients. We have recruited 3 patients, 2 of whom have improved significantly. Iptacopan is currently under use under the Apple House trial in the United States, Brazil, the Indian subcontinent, China, and Taiwan. And they are aiming to recruit 50 patients who will then go on to a prolonged 6-month maintenance phase. So in summary, TMA in AKI is indicated by microangiopathic hemolytic anemia, thrombocytopenia, and most often an active urinary sediment and a trigger. A renal biopsy is required when the complete picture of hemolysis is not available. Definite treatment for pregnancy-associated TMA has improved patient and renal survival. The role of plex seems to be declining, but in our setup, it's still first-line therapy, especially if there is anti-factor H antibody disease. Genetic testing should include whole exome sequencing and copy number variation, and plex is still the mainstay of treatment till the complementary blocking agents become available. Thank you.
Is paraprotein-mediated acute kidney injury. So, first of all, I would like to talk about something about the paraproteinemia, and then the disease spectrum of paraproteinemia, which involves MGUS, MGRS, multiple myeloma, and Waldenstrom's macroglobulinemia, and also finally the acute kidney injury related to the paraproteinemia. So let's start with the blood cell development. And starting with the blood stem cells, there are two lineages. The first is the myeloid stem cells, which differentiate in the red cells, platelets, and myeloblasts, and then granulocytes. And for the lymphoid stem cells, it will differentiate into the B lymphocyte, T lymphocyte, and natural killer cells. And we will focus mainly on the B lymphocytes and the plasma cells. So when the B cells become mature, then it will release immunoglobulin. Immunoglobulin consists of two parts: the heavy chain, IgG, IgA, IgM, IgD, and IgE. And then the light chain, which consists of kappa or lambda. In a healthy bone marrow, the normal B lymphocytes and the plasma cell will release normal immunoglobulin. But when there is malignant transformation, for example, multiple myeloma, there will be clonal proliferation of the B lymphocytes and also the plasma cell, which will release abnormal immunoglobulin. So paraproteins, in fact, are abnormal immunoglobulin produced by the clonal proliferation of B cells, most commonly plasma cells. It can be intact immunoglobulin, usually IgG, IgA, and IgM, or part of the immunoglobulin, usually the light chain, rarely heavy chain. When the light chain occurs in the serum, then it's called the serum-free light chain. When the light chain occurs in urine, it's Benson's protein. So paraproteinemia, in fact, represents a group of related disease characterized by the unbalanced or disproportionate proliferation of immunoglobulin-producing cells, usually from a single clone. And these cells frequently secrete a structurally homogeneous immunoglobulin, or what we call the M protein. So paraproteinemia, in fact, consists of monoclonal gammopathy of undetermined significance, or what we call the MGUS, multiple myeloma, lymphoproliferative diseases, plasmacytoma, heavy chain disease, Poem syndrome, amyloidosis. So monoclonal gammopathy, in fact, is the presence of the abnormal monoclonal immunoglobulin in blood. It can range from asymptomatic conditions like MGUS to more severe but less common conditions like multiple myeloma and other lymphoproliferative malignancies. MGUS is a pre-malignant condition characterized by the presence of serum M protein concentration less than 3 grams per deciliter, and the bone marrow shows less than 10% of clonal plasma cells. There is also absence of Krebs symptoms. Krebs means hypercalcemia, renal insufficiency, anemia, and lytic bone lesions. There is also no evidence of amyloidosis. Why there is MGUS is still unknown, but it is found that with increasing in age, there is increasing incidence of MGUS. So based on the heavy chain, IgG is the most common type of the MGUS, followed by IgM and IgA. And in rare cases, there may also be biclonal gammopathy. The average risk of progression to multiple myeloma is around 1% per year. And typically, patients with IgG or IgA MGUS will progress to multiple myeloma, and patients with IgM MGUS will progress to Waldenström macroglobulinemia and other lymphoproliferative disorder. And the light chain MGUS is the precursor of light chain multiple myeloma and is defined by the abnormal kappa-lambda free light chain ratio. And the light chain MGUS may also progress to light chain amyloidosis or a light chain deposition disease. In a study carried out by the Mayo Clinic, 213 patients with IgM MGUS were followed up for more than 1,500 patients years, and lymphoma was found to be developed in 70 patients, Waldenström macroglobulinemia in 6, primary amyloidosis in 3, and chronic lymphocytic leukemia in 3. So this diagram shows the disease progression from MGUS to multiple myeloma. It can go through a stage what we call the smoldering multiple myeloma. It is similar to multiple myeloma, but there is no Krebs features in smoldering multiple myeloma. So another topic is the monoclonal gammopathy of renal significance. This term is introduced in 2012 because it is found that some individuals match the criteria of MGUS, but there is kidney damage. Why there is kidney damage? There are two theories. One is the direct deposition of the immunoglobulin, and the other is due to the indirect functional interference of the monoclonal immunoglobulin. And kidney biopsy is required for the definite diagnosis. And clinical histopathological subtypes of the MGRS are mostly glomerular and include lesions such as immunotactoid GN, proliferative GN with monoclonal immunoglobulin deposits, and also C3 glomerulopathy. So, based on the monoclonal IG deposits on the electron microscopy, the kidney lesions can be classified into organized, non-organized, or absence deposits. For organized deposits, it can be further classified into fibrillar, microtubular, and crystalline deposits. The renal symptoms include proteinuria, nephrotic syndrome, renal impairment, microscopic hematuria, etc. And extrarenal symptoms include heart failure, cardiomyopathy, liver, GI tract involvement, carpal tunnel syndrome, etc. So, in an observational study of around 3,000 MGUS patients, MGRS was detected in 1.5%. with an estimated 10% risk of progression within 1 year after the diagnosis. And the MGRS patients are at increased risk of progression to multiple myeloma than the MGUS. And approximately 72% of MGRS patients have progressing renal insufficiency. The mortality of patients is related to the increased risk of CKD, malignancy, infection, and other organ dysfunction. So plasma cell myeloma consists of smoldering plasma cell myeloma and symptomatic plasma cell myeloma. As I have just talked about, is whether there are CREB features that differentiate between them. Waldenstrom's macroglobulinemia is also important. It is a lymphoplasmacytic lymphoma with IgM and monoclonal gammopathy. Patients usually present with fever, weight loss, light sweats, organ involvement like lymphadenopathy, hepatosplenomegaly. Complications are usually due to the presence of IgM protein. And the diagnosis criteria include IgM monoclonal gammopathy with more than or equal to 10% clonal lymphoplasmacytic cells in the bone marrow. And besides, there are also mutations in the MYD88 gene in most of the patients. So, why patients with paraproteinemia got acute kidney injury? There are several reasons. The first one is due to the prerenal cause. It can be due to the volume depletion from nausea, vomiting, diarrhea, or due to renal salt and water loss. Salt wasting from tubular insufficiency and due to the use of some chemotherapeutic agents. And the tubular injury can be related to the use of NSAID or other nephrotoxins, contrast, hypotension, etc. And it can also be metabolic cause such as hypercalcemia and tuberculosis syndrome, and also cast nephropathy and glomerular injury. I will focus more on the cast nephropathy and glomerular injury in my later part of the talk. So the disease pattern, in fact, can be classified according to the part of the nephron that is being affected. Some disease affect the glomerulus and some affect the renal tubules. For the glomerulus, there can be amyloidosis, monoclonal immunoglobulin deposition disease, and also different forms of glomerulonephritis. For tubular, it's mainly the cast nephropathy. So this is just a table summary of what I have just said. So first of all, the disease of tubular nephron. Cast nephropathy is the most important one. It's the most common cause of the renal impairment in patients with multiple myeloma, and the monoclonal free light chain will bind and precipitate as heme phosphoprotein in distal nephrons. The cast will cause tubular obstruction, which trigger the immune response and cause a giant cell reaction and interstitial inflammation. Cast nephropathy can also be present in patients with Waldenström macroglobulinemia and also CLL. And the diagnosis is by renal biopsy as shown in the figure on the right-hand side, which shows some eosinophilic cast on H&E staining. In fact, other lesions such as AL amyloidosis and also the monoclonal immunoglobulin deposition disease may coexist together with carcinopathy in patients with paraproteinemia. And serum free light chain assay is the most sensitive method for the diagnosis, and proteinuria, especially in all patients, the most important part of the treatment is to decrease the secretion of the free light chain. It involves to use the plasma cell treatment as soon as possible. The treatment mainly consists of free drug regimen. One should be the bortezomib, and the second one should be either cyclophosphamide, thalidomide, and also the doxorubicin. And the third one is the high-dose steroid. So there have been conflicting evidence whether we should use extracorporeal devices to remove the free light chain. There are two important trials. One is the MIR trial and the other is the ULIGHT trials. Both trials compare the high cutoff dialyzer with the normal dialyzer in patients with carcinopathy. So this is a table of the comparison of these two studies. The main difference is the outcome. You can see that in the MIR study, at 3 months, there's no difference between both groups, the high cutoff dialyzer group and the normal dialyzer group. But starting at 6 months, the patients with using high cutoff dialyzer have a better renal outcome than the patients on normal dialyzer. However, in the ULIGHT study, there have been no significant difference between both groups, no matter whether it's 3 months, 6 months, or 12 months. So it is still not completely understood whether we should use high cutoff dialyzer in patients with carcinopathy. So let's come to the disease of glomerulus. Amyloidosis is the first one. Systemic amyloidosis are characterized by the precursor protein misfolding, fibril accumulation, and insoluble amyloid fibril deposition in different organs. Kidney, heart, GI tract, peripheral nerves, and liver are most commonly involved. However, little is known about the mechanism underlying the amyloidosis. There has been postulation that mesangial cells, when with the presence of the pathogenic free light chain, can behave like macrophages and are active participants in generation of the amyloid fibrils. After endocytosis by the mesangial cells, these free light chains are processed by the lysozyme and may undergo incomplete proteolysis to form the amyloid fibrils. And these fibrils can extrude in the extracellular space, which cause the disruption of the normal mesangium. Amyloidosis is most common in plasma cell dyscrasia, but B-cell lymphoproliferative disorder can also result in the amyloidosis. AL amyloidosis is the most common subtype, and the lambda light chain being the most common Ig related. And this is followed by heavy and light chain amyloidosis, and the rarest one is the heavy chain amyloidosis. They have similar presentation. Most of patients have proteinuria, with half of them even have nephrotic syndrome. Half of the patient will have raised serum creatinine. Cardiac involvement is important because this determines the patient's survival. And the extent of the kidney involvement will determine the renal survival. So, the formation of amyloid fibrils is the cause of the organ dysfunction. Neuropathy sometimes can be seen. And in kidney, amyloid fibrils tend to deposit within the glomerular vessel wall, interstitium, and less common, the tubular basement membrane. And the diagnosis is based on the identification of amyloid fibrils in tissue with Congo red staining and apple green birefringence under polarized light. And this is a figure showing the AL amyloidosis. On the left-hand side, you can see that the mesangial regions are expanded with pale eosinophilic material, and on the right-hand side, you can see the apple green birefringence under polarized light. Then come the MIDD. Is characterized by the deposition of non-amyloid monoclonal immunoglobulin. There are 3 distinct disorders. The most common is the light chain deposition disease, and followed by the heavy chain, and the rarest one is the light and heavy chain deposition disease. And the light chain deposition disease and the heavy chain deposition disease are mainly recognized under light microscopy by the nodular sclerosing appearance of the mesangium. The nodular appearance may be preceded by the mesangial proliferative or membranoproliferative pattern of injury. So immunofluorescence microscopy will reveal the deposition of the free light chain in the mesangium and along the glomerular and tubular basement membrane. And ultrastructurally non-fibrillar electron-dense deposits are present in the subendothelial glomerular areas and mesangium. The renal manifestation include progressing renal failure, proteinuria, hypertension, and up to 1/4 of patients with LCDD will have symptomatic extrarenal deposition of light chain. On the other hand, in patients with heavy chain deposition disease, extrarenal deposits are rarer. And the management is the same. It's based on the underlying disease. So this is the figure showing the MIDD. I hope you could appreciate the nodular glomerulosclerosis in the MIDD. So other glomerular diseases associated with paraprotein include proliferative GN with monoclonal immunoglobulin deposits. It resembles immunocomplex mediated GN, but immunofluorescence staining detect a monotypical immunoglobulin. But the underlying pathogenetic process is incompletely understood. And the second group is the C3GN, which is identified by the accumulation of C3 but scanty or absent immunoglobulin deposition. And the final collection is immunotactoid GN and fibrillary GN or type 1 cryoglobulinemia. Besides all these glomerular diseases, in fact, there may also be some other form of GN, such as palsy immune GN. This is a case report published by our group several months ago, which involves a patient found to have ANCA negative palsy immune GN in a patient with Waldenstrom's macroglobulinemia. This is a 76-year-old gentleman presented with reverse AG ratio and also lymphadenopathy. Bone marrow and lymph node biopsy shows Waldenstrom's macroglobulinemia. Because of relatively asymptomatic, this patient was kept on observation, but 1 month later, he developed acute kidney injury with serum creatinine rise up to more than 300 micromole per liter. Autoimmune markers, including ANCA, was negative, and renal biopsy showed crescentic GN. And besides the crescents, there is no features of amyloidosis, no features of carcinopathy, no immune complex, or no light chain deposition. So this patient was treated with pulse methylprednisolone followed by oral prednisolone, together with the treatment of the Waldenstrom's macroglobulinemia, such as intravenous rituximab and oral cyclophosphamide for 6 courses. Besides hematological improvement, the serum creatinine maintains static at around 140 micromole per liter. In fact, ANCA negative palsy immune GN has also been found in patients with multiple myeloma. And in an observational study of around 40 or 41 cases of monoclonal gammopathy with renal involvement, all these patients have done a renal biopsy, and it's found that the light chain carcinopathy is still the most common form of renal lesions detected, followed by amyloidosis, MIDD, and proliferative GM with monoclonal immunoglobulin deposition, and AKI is the predominant clinical presentation in nearly half of these patients. It's found that all cases of light chain carcinopathy and MIDD have myeloma, and only around 45% of patients with amyloidosis have myeloma. All cases of proliferative GN with monoclonal immunoglobulin deposition had normal bone marrow finding. So this may be a patient with monoclonal gammopathy with renal significance. So in summary, paraproteinemia can result in a spectrum of renal diseases due to differences in pathogenetic process. AKI is a common presentation of paraprotein-related disease. Kidney biopsy is often required to provide the accurate diagnosis. Early diagnosis and initiation of disease-specific treatment is essential to improve the patient and renal prognosis. Thank you.